depending on how you define well-being, then obviously that will have implications for how you measure it. But what we do know is that there's variation between countries and within countries. We've got these, David Cameron in the UK is very keen on well-being measurement, and we've just had the latest measurement of these three. You can see three different measures there: happiness, life being worthwhile, and life satisfaction. And you can see actually there are quite good levels across the UK, but there's a significant minority whose well-being isn't so good. The different constituents of well-being are quite important, and when we think about these four constituents that Martin Seligman identified, the first one is pleasure, and obviously that's important. But engagement, so engagement both in relationships, work, a range of activities, but also meaning and purpose are very important. And those middle two, engagement and meaning, certainly are more kind of sort of consistent, I guess, with something like with Greek philosophy. Aristotle talked about the good life, so it's more than just pleasure. And then you've got this fourth one that Martin Seligman recently added on achievement, and achievement in a broad sense. And the maximum well-being occurs from not just focusing on one particular constituent, but actually trying to get a bit of a balance. The impact of mental health and well-being I was highlighting in the introduction, but it's more than just the absence of mental disorder. And because of the broad range of impacts, it's really integral to any promotion activity that we're doing. It's also very important in preventing mental disorder. And the health impacts, I put this slide earlier, but really the health impacts of improved mental health and mental well-being are across both mental health, physical health, and healthcare utilisation. But as I said earlier, across a broad range of areas outside health. I mean, if we're thinking about children and adolescents, we know that if happy kids are much more likely to study well, they're much less likely to get into trouble, and actually a broad range of outcomes that you can see there. Those impacts actually have quite a significant economic effect. I seem to have lost my. Thank you. Thank you. Oh, that's better, right. So yeah, they have quite a few economic impacts, and there's been less work done on that, but David will go into that. In terms of the relationship between mental well-being and mental disorder, sometimes these things do get a bit polarised, but what we know is that if you've got good well-being, it reduces your risk of mental disorder. If you've got mental disorder, you're much more likely to have lower well-being. And the single largest group with poor well-being are actually that group with mental disorder. So if we're looking at then mental disorder, we can see that there's going to be a similar level of impact as we see for mental well-being. We just wanted to highlight these figures from WHO, which give us a sense of the very large impact of mental disorder compared to, for instance, other areas which may be also focuses of health promotion. And you can see that actually the very significant proportion of overall disability adjusted life years, which is one measure of burden. But even these estimates are very significant underestimates, because they don't measure a large number of mental disorders. And the size of that impact is due for these three main reasons that I'll go into. The first is that most lifetime mental disorder arises by early adulthood. And that's several decades before associated physical illness. And we know also that similarly, well-being arises very early. And again, that's in distinction to physical illness. Secondly, there's a very broad range of impacts, and as I said, similar to mental well-being. If you look at the impacts of mental disorder during childhood and adolescence, those occur both in health, but also areas outside health, and again, a broad range of areas. And I wanted to highlight, this is a study we do a big survey every 7 years in the UK, which measures the levels of mental disorder both in children and adolescents, but also adults. And on the left-hand column there, you can see a range of health risk behaviours. And then the two middle columns are the most common mental disorders in childhood and adolescence. So you can see that for those range of health risk behaviours and adverse outcomes, there's a several-fold increased risk of health risk behaviours in children and adolescents with mental disorder. And those impacts don't just stop when the child and adolescent becomes an adult. They translate into a broad range of outcomes in adulthood. And similarly in adulthood, if you've got a mental disorder, it results in a broad range of outcomes. Smoking as an example, we can see that actually it's over 40% of adult tobacco consumption, both in the UK, the US and Australia, is by people with mental disorder. The reason for that is obviously you all know that tobacco is the largest single preventable cause of death. And often mental disorder is not even acknowledged in terms of intervention or outcomes. The impact of mental disorder on physical health is also very significant, and the red figures here are the average number of years of life lost with different mental disorders. And you can see that the size of years lost is quite extraordinary for all these different mental disorders. This has an economic impact in Europe. The cost of mental disorder is close to 800 billion euros each year. To the UK economy, similarly very large. And I just highlighted a crime figure there. The third reason for the impacts of mental disorder are the numbers of people affected. It's over 30% of people in the European Union each year experience a mental disorder, equivalent to over 136 million. These are the different types of mental disorder for people who may not be so familiar, but this is just the adult psychiatric morbidity survey, just highlighting the levels, and you can just get a sense that this is actually quite a heterogeneous group. Some people will never see a psychiatrist, others will see would see a lot of psychiatry for their treatment. The risk factors for mental disorder and protective factors for well-being, very important in a public health approach, because what we'd ideally like to do is to think about upstream how we promote well-being across populations and how we prevent people becoming unwell in the first place. And what's important to appreciate is that actually different organisations, government departments have roles in different risk factors and protective factors, and this highlights the importance of coordination. I've highlighted a broad range of protective factors for well-being here, and as you can see, it's quite broad and fits into different policy areas. But really just wanted to focus, particularly at the bottom there, on meaning, purpose, spirituality, and culture. And culture has a huge opportunity to actually promote well-being through values, and I know Brian's very interested in, for instance, meditation, mindfulness, and some of those protective factors can be very much embraced and supported through culture. The risk factors for mental disorder follow a sort of similar profile to risk factors for other disease. Certainly during pregnancy, abuse of substances and tobacco use is associated with increased risk of mental disorder. But socioeconomic inequality is also very important. So a threefold higher rate of mental disorder in children and adolescents from lowest household income group compared to top. Parental factors are very important, parental mental health, but also parenting has a huge impact on the risk of mental disorder. And similarly, child factors, I just wanted to highlight, I've got the third one there, screen time, was an announcement today by Public Health England about something that they're doing, which is giving parents information about the impacts of too much screen time. In the UK, it's an average 6 hours a day is spent on the screen by children and adolescents outside school time. So you can see that that's displacing a lot of other activities which would be otherwise promoting well-being, preventing mental disorder. Most importantly in childhood and adolescence, childhood adversity has probably the largest single impact on risk of mental disorder. And you can see here in terms of the second bullet that sexual abuse in childhood is associated with well, 15-fold increased risk of probable psychosis, but it's not just the more severe end, it's across a range of disorders. And similarly, we don't have the information on well-being, but we can be pretty sure that there's going to be a big impact on well-being too. The impact of risk factors in adulthood is generally less, and you can see that the size of the impact is lower, but again is very much reflecting risk factors outside health across a broad range of the environment. It's not just the size of the impact of risk factors, but it's the proportion of the population affected by those risk factors. And I've just highlighted startling figures from the UK, which show the proportion of children and adolescents experiencing abuse, for instance. And therefore, this can be particularly important in the case of the UK. It's our social services who then would have a duty to intervene to protect. But I think more generally, at a public health level, to highlight this issue, to support parenting, to prevent abuse, and a range of other interventions are very important. Inequality underpins a broad range of risk factors for mental disorder and poor well-being. And so actually it's an important area to address to prevent mental disorder and to promote well-being. But also, mental disorder then results in a broad range of further inequalities that we can do further prevention activity on. Really what I'm saying here is that there is a great opportunity to promote mental well-being and prevent a large proportion of mental disorder through these upstream approaches. If we can look at the various risk factors and then do something about those risk factors, and promote protective factors, we're in a great position to actually reduce this extraordinary burden and cost of mental disorder, but also make society a much happier, well-being orientated place. And such a sort of twin track approach is reflected in the UK's mental health strategy. It's important that any interventions or strategy recognise that certain groups have much higher risks of both mental disorder and poor well-being, and that such groups actually proportionately benefit from any interventions that are going on. And this has been reflected in a number of current discussions, both at the UN around what happens post-2015. And we know it's possible to estimate the numbers of people from those high-risk groups at a locality, regional or national level. And I'm just highlighting, for an example, just a number of different high-risk groups in the UK, but they can be obviously, they'll be relevant to, and they'll be different in different countries and cultures. And you can see the several-fold increased risk of mental disorder and poor well-being in these groups of children. And similarly in adult groups, certain groups have much higher rates of mental disorder, several-fold. I've just highlighted long-term physical conditions there. If you've got 2 or more long-term physical conditions, you're at a 7-fold increased risk of depression. And so that has implications in terms of, well, if we know that, then we should be targeting this group, both for treatment but also upstream promotion, prevention, because we know we can actually reduce the translation of that higher risk into illness. In terms of interventions to promote well-being and prevent mental disorder, there's an excellent evidence base, and that's been highlighted consistently, certainly in the UK, in the last 2 mental health strategies. And I've just highlighted just the level of evidence base for a range of interventions. A is the highest level of evidence. We've got randomised controlled trials coming out of your ears. B is we've got a couple of randomised controlled trials, and you can see that as you go down the list, the evidence base becomes less strong, but often it's reflecting research priorities, research investment. In terms of mental health promotion, what's helpful to look at or define in terms of interventions is interventions at primary, secondary and tertiary levels. And primary, where we're promoting protective factors for mental well-being across populations. Secondary is where we're targeting particular groups at higher risk of poor well-being, and tertiary for people with existing health problems to promote recovery. And one of the things in the UK, so I've been involved in a piece of work where we've looked across the life course to promote well-being in this way. And if we're starting well, so looking at parental mental health, we've got really excellent evidence base both to support parental mental health and physical health, parenting schools, but also support the early development of the child in terms of their well-being. And similarly, we've got very good evidence base in terms of developing well, so mainly school-based interventions, which can also prevent mental disorder from happening and result in a broad range of impacts, which kind of mirror the impacts that I highlighted earlier. School-based mental health promotion, particularly, you can see the level of evidence base is excellent, and particularly long-term whole school approaches involving teacher training and parental participation are associated with increased effectiveness. This programme in the States, involving over 250,000 students in its evaluation, is just an example and shows that there's reductions in both mental disorder, but also improved social and emotional skills, attitudes about self, and of course at the bottom there, improved academic performance on top, which again reflects that your well-being, if you're feeling happier, you're able to study and do better at school. In terms of living well, it's a broad range of interventions, and you can see that the evidence base is less strong here, but still very impressive, and really kind of mirrors a broad range of different organisations, different sectors across the community. And you can see that all of these are important in promoting well-being, and there may be different kind of aspects of this going on in any particular community, but also there'll be opportunities to actually engage, invest, promote particular types and particular communities. So great opportunities. Engaging well, I've used as a term, but really to support connection between people. So we know that social capital is very important for well-being, and that certain interventions can promote that connection between people, which promotes that social well-being. And again, there are a range of interventions. You can see that the level of evidence isn't so strong. Working well in the workplace, we spend a lot of our working day in the workplace. There are particular interventions that can promote our well-being there, reduce stress. I know there have been lots of sessions going on about workplace health promotion. But if we're looking at mental health promotion, stress reduction, that's very important. And also if we're thinking around targeted approaches, for instance, to people recovering from mental disorder, that's very helpful to actually reducing their time in hospital. Ageing well, a broad range of interventions to promote the well-being of older people. And again, you can see that the evidence base for those interventions is, again, very high. I've just put here at the bottom that promotion interventions are great, and they can also, on top of promoting well-being, mean that people are at much lower risk of developing mental disorder. But if we come to a way of looking at prevention, what I've tried to do here is to frame it again at a similar primary, secondary and tertiary level. So when we're looking at primary prevention, we're addressing upstream risk factors. Some of those risk factors I highlighted earlier, such as abuse, for instance. We know that certain groups I showed are a much higher level of disorder, so they need a more targeted approach. But we can then do a secondary prevention, so at the earliest stage of a disorder we can recognise it early, and that early intervention is associated with a broad range of benefits. And because I also highlighted it's half of lifetime mental illness has started by the age of 14, 3/4 by the mid-20s, if we can offer people support at that earliest stage, we know that actually their outcomes are going to be much better. And then tertiary prevention is basically targeting people with established mental disorder to promote recovery. And then these various prevention interventions, and again you can see the level of evidence for them, but I've highlighted both prevention, mental disorder and dementia, but also health risk behaviours, inequality, discrimination, stigma, suicide, violence and abuse. Just wanted to highlight school-based violence prevention programmes. Violence and abuse we know are important risk factors for mental disorder and poor well-being. There are very effective interventions to address that, and that's again outside the health system, usually in schools, and very effective programmes to both prevent violence in school, prevent sexual abuse, bullying, but also of course to intervene early if we know it's there. Prevention of health risk behaviour, again good evidence around school-based programmes, but we know that actually health risk behaviour arises pretty early in the life course, probably at a similar time to when mental disorder arises, and so we can prevent both health risk behaviour and associated mental disorder. And really this kind of brings me to the point around the importance of integrating mental health into programs that are addressing health risk behaviour that often tend to be separate. You're addressing smoking, alcohol, drug misuse, sort of unhealthy eating, but actually if we can mainstream and integrate mental health and well-being into that, I think we can really enhance outcomes of interventions. Early recognition of mental disorder associated, as I said earlier, with much better outcomes, and essentially there's a great opportunity to prevent a large proportion of mental disorder if we can intervene early, from particularly one study of Kim Cohen at the bottom there. The economic impacts of interventions, certainly this was highlighted in the London School of Economics work for the UK's mental health strategy, and the savings are, even in the short term, a large proportion accrue in areas outside health, and there's a cost of not providing such interventions. The figures in red here are the net savings for each pound spent on a range of prevention interventions. So you can see that actually, if you were playing the stock market in any country, and these were the savings that you were getting for each pound, euro, or whatever that you were spending, you'd be going straight for this. And similarly, for prevention of conduct disorder through social emotional learning programs, for each pound you spend, you get net savings of £84. And so there's actually a very important economic issue surrounding this, both in terms of economic recovery, but also economic protection and economic health of a region or a nation. The impacts of interventions, they're very broad, and really the slides that I highlighted earlier are just emphasising that both the mental health, mental disorder, and addressing those areas result in a broad range of impacts both within health and outside health. And actually the interventions are coming from a broad range of sectors, both primary and secondary care, but public health, local government, and you can see that it's very broad, and the need actually to have mental health integrated into each of these organisations, but also to facilitate cross-sector coordination between those, so each of them are working in a joined-up, coordinated way. And I've just given some examples of the levels that different organisations can work at. So again, different organisations are working at different levels. They're not all doing the same thing and very much complementing each other. We can assess what different organisations are doing, where they fit together, through a kind of needs analysis, or an assessment of what different work is going on at a locality level or at a regional level. And this is very helpful in terms of highlighting to a broad range of stakeholders that actually what they might not be realising, but they are promoting well-being and preventing mental disorder, but is also helpful to embed some of this mainstreaming and integration of mental health. The intervention gap is very significant. Very briefly, that it's only 10% of people with mental disorder in the European Union get any treatment. They're also much less likely to get help for their much higher levels of health risk behaviour and poor physical health. It's even less in low and middle income countries. But in terms of mental health promotion, even in the UK, it's less than 0.1% of the mental health budget. And there's a lack of integration of mental health into health promotion and public health, despite the broad range of impacts I've highlighted. And that gap actually results in a huge level of suffering, impacts and costs. And those impacts continue across the life course. However, we can actually estimate both the size, the impact and the cost of such a gap, and that's very helpful in informing policymakers at local, regional and national levels. And just to say, a piece of work that I've done, really sort of highlighting estimation of both the level of risk factors and protective factors, numbers from high-risk groups, and the proportion receiving different levels of intervention, which can then enable us to sort of get a good idea about what's going on at the moment in terms of impact, what is of those interventions, including economic savings, but also the impact of that gap. The transparency of provision of such interventions is helpful. It informs strategic planning and potentially investment. So basically the key message is mental health, a broad range of impacts, a central part of health promotion. Cost-effective interventions exist, both to promote mental health, prevent mental disorder. But there's virtual absence of implementation, which results in significant impacts and costs. We can estimate the size, impact and cost of that gap, and that's particularly helpful in increasing awareness across a broad range of stakeholders, and that mental health, public mental health training for promotion interventions, promotion professionals is important because it enhances a broad range of outcomes associated with promotion. A few references there, my email contact, very happy to take questions maybe after we've each given a presentation. We'll have a bit of time for discussion at the end. So I'd just like then to maybe go straight into David McDade's presentation. So David is an economist at the London School of Economics and done a huge amount of work on mental health promotion, mental disorder prevention in terms of the economics and the cost. So over to you, David.
Thank you. I think we should give Jonathan a round of applause. Sawas Day, hello, I hope that was understandable in time. I'm going to talk a little bit for the next few minutes about the economic case for investing in mental health. And I want to argue there is a compelling case, and I also want to get a message out generally to health promoters that when you're making an economic case on the benefits of health promotion, you often mention, or some people mention, the impacts on physical health, on cardiovascular health, impacts on smoking. There will be additional benefits on mental health to also flag up. So this is not just about saying we need to do more about mental health, it's also emphasising that there are mental health benefits of many health promoting interventions, and yet they tend not to get mentioned as much. So what am I going to talk about? I'm going to say, is there actually an economic argument for investing in mental health? How can people like me, I'm an economist by background, how can we use our economic arguments to help make this case? What do we know at the moment, and how can we strengthen the evidence base? Well, I would like to argue that all over the world, potentially there are substantial economic benefits to be gained by improving and protecting mental health. This is a slide from the World Economic Forum. Some of you, probably most of you in this room, will be aware that in New York, at the United Nations in 2011, there was a conference on non-communicable diseases. And yet at that conference, there was almost no mention whatsoever about mental health, for various political reasons. But some work that was produced for the conference by the World Economic Forum, you can see here how much of a contribution to the overall costs of non-communicable diseases actually come from mental health problems. So 16.3 of the trillions of US dollars worldwide on health problems were actually due to mental health problems, actually more than cardiovascular disease and double that for cancers. Now, this is not a competition between diseases. I'm trying to emphasise that. And there's an awful lot of multi-morbidity and comorbidity in all of this. But I would argue that we forget mental health at our peril, because it has such profound impacts. And this is in both high, middle and low-income countries. The other important thing about poor mental health, which is also applicable to other health problems as well, of course, is that we're talking again, as we've heard at much of this conference, about impacts beyond the healthcare sector. And this is an analysis done in England that, well, I've put it together, taken together 3 different sources that have used broadly similar methodologies to evaluate the costs of illness for cancer, for cardiovascular disease and for mental health. And the point here again is not to argue it's a competition, but simply to flag up, to make people aware that there are substantial costs outside of the healthcare system as a result of poor mental health. Around 2/3 of the costs of depression and anxiety-related disorders fall outside healthcare systems. They fall, there are impacts on work, impacts on performance at school, there are impacts in terms of the social inclusiveness of individuals in society, the terrible impacts to do with suicide and premature mortality from physical health problems. So there are really major impacts on economies, and some of this is avoidable through better health promotion. One big driver of the interest in mental health in the UK in recent years has been the amount of money it costs our economy in terms of paying disability benefits. Around 40% of all of the disability benefits we pay to people who can't work because of health problems are to do with mental and behavioural problems. And much of this is to do with depression, anxiety and stress-related disorders. And that really has woken up government departments actually to start collaborating with each other to deal with some of these issues. So there is a good working relationship between our Ministry for Work and Labour and our Ministry for Health to think about some of the issues around mental health. And it's really striking because we spend more in the UK, or Great Britain to be precise, England, Scotland and Wales, Great Britain, on disability benefits for people with mental health problems than we pay out in unemployment benefits. Okay, it's a big, big cost to the economy. And again, if you talk to people with mental health problems, most of them will want to be working. They want to participate. They want to be included in society through work, and they're often denied that opportunity as well. So it's an important point from both perspectives. Another thing to say, these costs are long-term. This is another British slide. It indicates that if you are out of work and claiming what's now called employment and support allowances, our kind of benefit system, you are much more likely to be out of work for a long time if you have a mental health problem compared to nervous system problems or heart problems or back-related musculoskeletal problems. Much longer time out of work. That has a cost to the economy. It has a cost to the individual because they have less disposable income, and it also has a cost perhaps to their own perception of their status within society as well. And I should also say, it has spillover costs on their families as well. So there are long-term costs, much longer impacts for if you're out of work because of a mental health related problem compared to some of the physical problems. And I could spend hours presenting data on some of these examples, but just a few very quick ones. Here's just a study from Korea, South Korea, again emphasising the economic impacts of depression in Korea. And the take-home message here is that most of these costs fall outside of the healthcare system in terms of time off work, in terms of presenteeism, this business of being at work but not really functioning very well, and also premature mortality, which in part is due to suicide, but it's mostly due to early death from physical health problems. Okay, big costs, and the same can be seen in many countries. There was a nice study done in Australia recently on the impacts of poor mental health on young men. And again, the point here to emphasise that the government is paying a lot of these costs, around 31% of the costs of helping people through welfare and so forth because of their health problems, and it's costing an extraordinary amount to the Australian economy in terms of lost opportunities for study and for work. And again, I could have shown slides from many countries demonstrating the same points. I think this is a profound slide for those who can hopefully read it, about the profound impacts of premature mortality. And there may be a perception sometimes that all we're talking about here are people with psychosis or very severe mental disorders. But in fact, this study from London shows that people living with depression, on average, they have a life expectancy of 66.8 years, which that's for men, and that's 10 years less than the average life expectancy of a man in the UK for someone living with depression. If you're living with schizophrenia, it's a 14-year difference. And even for women, it's a 7-year difference in life expectancy between people living with depression and people living without. I mean, this is slightly the more severe end of things because these are people in contact with specialist services. But nonetheless, you know, this is a major public health issue. The difference in life expectancy between people living with mental health problems and those who aren't, which raises a couple of issues actually. Again, there's the issue of primary prevention in the first place, but then there's also the issue of tertiary prevention. If you're dealing with someone who has a physical health condition, how do you make sure you try and manage their mental health in a better way as well, and prevent the onset of mental health problems which can be associated with physical health problems as well. And just to emphasise this point, we did some work in England with the King's Fund, an NGO, health policy NGO in London, looking at the overlaps between people living with long-term chronic physical health problems and those living with long-term mental health problems. And you can see there's a substantial overlap there with 30% of people with long-term physical health problems also living with a mental health problem, and 46% of those with mental health problems living with a physical health problem. And we estimated that about £1 in every 8 for people living with a long-term physical health problem is actually spent on their mental health needs. So, you know, multi-morbidity, comorbidity, very, very, very important issues. And another important point from an economist point of view, and if you're trying to convince people to invest in mental health, actually, if you invest in the protection of mental health of people who are living with chronic physical health problems, it has a positive impact on the cost of managing physical health problems. This is an American slide. All of these conditions, there's a statistically significant difference between the physical health treatment costs of people living with a range of chronic health problems who are depressed and who are not depressed. And there's good evidence, particularly around the area of diabetes and depression, where you have depression management interventions for people who have chronic diabetes, then the cost of managing their diabetes care is lower, and there's a lower risk of complications, diabetes-related complications. People like Wayne Caton in the States have done some excellent work in this area. Another thing to emphasise, as with mental health, and this applies to other areas as well, but the impacts can be incredibly long-lasting. And we know that, interestingly enough, because it's an area where we do have some longitudinal studies, where children born in the 1940s or 50s, even in some countries, have been followed up for very long periods of time. We can identify, going back to identify children who appear to have had behavioural and mental health related problems, and we can look at their life outcomes. And we can see the consequences of having these problems in childhood. And I'll give an example of this. This is one example from excellent work that goes on in New Zealand from David Ferguson and colleagues. This is the Christchurch cohort study. It's been following a group of children since the ages of between 7 and 9. And this slide here, it identifies this population sample of children, those who had the lowest level of any kind of behavioural problems, and then the 5% who had the most severe behavioural problems identified at the ages of 7 and 9. So we're talking here about people who had conduct disorders and the like. And then these are the outcomes at age 25. Okay? These children we followed to the age 25. It's extraordinary the differences. 52% of those who had the severe problems in childhood had no qualifications at all by the age of 25. No one went to university. They were much more likely to be unemployed, much more likely to be claiming welfare benefits, much more likely to be a teenage parent, much more likely to be imprisoned, and much more likely to be drug dependent. And if they were working, their income would be lower. All of these differences were statistically significant. And I could again have shown slides from parts of Europe, parts of North America, that make exactly the same points. There are long-term consequences of poor mental health. And again, it puts a lot of emphasis on the area of children doing work in schools and indeed before schools to promote and protect the health of children, given the long-term consequences of poor mental health for the population. I won't dwell on these slides, but again, at this time of economic recession, in some countries of the world at least, there are risks, long-term risks, as a result of long-term unemployment increasing, consistently issues around higher risks of suicide. Again, as health promoters and public health professionals, what should we be doing to try and mitigate some of the risks of losing a job? Thinking about those issues, can we think about resilience measures, coping measures to deal with the onset of unemployment, etc. And we know if we forget this, it has consequences at our peril. Again, in South Korea, the economic crisis in the 1990s, that has been associated afterwards with over the last 10 years, with a real discrepancy in the rate of suicides between those who were left behind financially, who did not recover after the economic crisis, compared to those who did, with much higher rates of suicide being seen in those lower socioeconomic groups. And again, it raises questions again about what could we do something now to try and prevent some of those impacts through both mental health interventions and of course through more general measures around poverty reduction and income support and so forth as well. So how can economics make a case? I hope I've put forward some arguments to say there are costs. There are costs of not doing anything at all for mental health. You know, it's not a free issue. I mean, it does have consequences. Well, of course, we could do lots of randomised controlled trials, and of course we should do those, and we should add some economic evidence to those randomised controlled trials. But, you know, we all recognise that there are limitations to the use of trials. They're not always easy to do in some areas of complex interventions in public health. They take a lot of time, sometimes they take a lot of money. But economists can bring another tool to the table, which is to model some of the economic benefits of investing in different interventions. So what we do is we synthesise existing evidence on the effectiveness of interventions, we look at the costs of delivering those interventions, and we look at what the evidence from the existing literature says about the short and long-term effectiveness, and we try and adapt the model to each local circumstance. So if we're thinking about Thailand, we might be looking at a different set of interventions compared to if we're looking at the US or France or something. So it's tailored to local circumstances. We're comparing costs, we're comparing outcomes, and then we're deciding in our own societies what we consider is worth doing. That's a value judgment for each society to make. So what do we know about the case for action based on some of this stuff? Well, I'm going to refer a bit here to a couple of reviews, including one I did with a colleague in 2011, that's in Health Promotion International, where we reviewed some of the literature on the economic case for investing in mental health, and one or two other studies as well. And I'll also mention some modelling work we did for the Department of Health, and some excellent work done in Australia as well, a part of the Assessing Cost Effectiveness of Prevention programme, the ACE project, that was done a few years ago now in Australia. A few observations. The literature, and it may be a bias of our searches, I don't think it is. It's dominated at the moment by the English-speaking countries and by the Netherlands in terms of economic studies in this area. So there are large gaps around the world in collecting this kind of evidence. There are challenges in the quality of the evidence that's collected, of course, and sometimes it's difficult, and this applies to the effectiveness reviews, what the comparator actually is. Is it do nothing or is it something else? And there are challenges. I think studies miss out by not looking at some of the impacts beyond the healthcare system sometimes. But some examples of what we found, some really profound ones, really. Nurse-family partnerships. This is not new. David Olds was talking about this probably in the 1980s, I guess. You know, you have an access. Mothers and young children, the first years of life, have access to the health visitors, to nurses. It has a return of 2.88 for every dollar or baht or whatever you spend over it was, I think it was a 4 or 5 year period initially, and there are longer term benefits as well in terms of health benefits, employment benefits for the children and for the mothers. Another school-based intervention, the good behaviour game, about instilling good behaviour in children in schools, generated a benefit to cost ratio apparently of around 25 to 1 for investing in this very low cost intervention in schools, which has tried to motivate and make it routine for children to have good behaviours in schools. Seattle Social Development Project, again, benefits to cost ratio of 3 to 1. And these are all mentioned in the paper that we did, and Caring Schools Community Project as well. I should say that this particular issue of the journal, it has specific papers looking at the evidence on schools, on parenting, also on workplaces and interventions for older people as well, in addition to our paper on economics. Others on parenting, Jonathan's already mentioned good evidence on parenting. There's good evidence on the cost effectiveness of parenting in different contexts, high income country contexts, from the UK, from the US, from Australia as well, different programs, a lot of manualised programs to deliver interventions, but also some very simple things like advice to new mothers on trying to encourage better infant sleep, which I know is a challenging thing to do, but that has an impact on maternal well-being, clearly, and that's been shown to work in an Australian context. This is a difficult slide to read, but it's an important slide. This is actually an ongoing study in Canada. The Better Futures program going on in Ontario at the moment. And it's not just a health intervention, it's an education-based intervention as well, delivered to children in I think from 4 or 5 in schools in Ontario, and then continuing to deliver over time. It's going to be a 25-year follow-up, I think, when it's finished entirely. But these are the 10-year data. And what you find here, you don't need to read all the data now, is basically there's a net benefit to the Ontario government because of savings through the education system as a result of investing in this program. There are a few additional health costs because people spend a bit more money on health-related interventions, but overall, on average, there's a $3,000 benefit to the Ontario government of investing in this program, simply negating the costs and the benefits. And I think these kind of figures can be compelling when we're talking about interventions that aren't necessarily funded by health departments. They're funded in the education ministries, or we're trying to convince employers to do things as well. Talking about employers, again, some examples of work-based interventions. We did some work as well for the Department of Health in England on this. There's a nice study by Mills and colleagues of a multi-component workplace programme which actually looked at the economic costs and valued impacts in terms of absenteeism and presenteeism. A return on investment to the employer of around 6 to 1 of investing in a workplace health promotion programme. And we had a nice session yesterday afternoon where there was a presentation from Switzerland, for instance, where they've done something more complex, in fact, and also identified benefits in terms of absenteeism, in terms of productivity, and indeed reduced healthcare costs. So some interesting stuff going on there for workplaces. And in workplaces, we're trying to convince the businesses to invest the money. It's not necessarily about governments, although governments could invest some money because small businesses can't do these things themselves, and there's an economic benefit for the government as well as for the business. You can also find things for older people, so it's not just about the young. For older people, very simple interventions. For instance, exercise. So there were some exercise programs around Tai Chi, and the benefit on this particular study was not necessarily the Tai Chi itself, but it was the fact that people did it together in a group. So it was the reduction in social isolation. Actually getting people out of their houses, talking to other people, really does have an impact on mental health. And again, there are interventions which appear to be very cost effective for early intervention to prevent depression, or for those who are at high risk of depression, such as people who've lost a life partner in the recent past. So whatever area you look at, and in this review we looked at younger people, the workplace, and older people, you can find interventions that can be cost effective in their context, backed up by randomised controlled trial evidence. There's a lot of work we're doing now, which I'm not going to talk about today, on interventions to deal with the crisis as well. Actually, we'll mention one around debt management, but there's a lot of work going on there as well, and I think that's an important issue because this crisis may be in Europe at the moment, but it'll be here in Asia at some point in time. It has been in the past, and even in Western Australia, things may not always be as rosy as they are now. Let me very quickly say a word or two about modelling work, very quickly. How am I doing for time? I don't think I've got much time. I just really wanted to highlight some of the excellent work done by Kathy Mihalopoulos and colleagues at Deakin University in Australia, where they did some work as part of this larger study, the ACE study, assessing cost effectiveness of prevention, for a whole range of interventions, not just for mental health. So in fact, you should look at the study anyway, generally for health promotion interventions. But they identified a number of things which are both cost effective. So for instance, just to give one example, in an Australian context, screening and psychological treatment to prevent postnatal depression does appear to be cost effective in an Australian context. But they also look at the strength of the evidence, and in this case, for the postnatal depression one, the evidence they acknowledge is limited in terms of the strength of the empirical evidence. And also they look at issues around the implementation. So there may be challenges there about the whole issue of implementing an antenatal screening program. So it's looking both at the evidence of what works, looking on the strength of the evidence, and then looking at issues around implementation, feasibility, those kinds of things. And I think it's a very nice analysis to look at. We also did some similar work in an English context, as Jonathan mentioned, for the Department of Health. We ended up modelling the economic case for 15 interventions where we could find sufficient evidence on their effectiveness, and we looked at their cost effectiveness. We tried to present to the government data on the impacts to the healthcare system, impacts to other parts of government, and impacts beyond government. And we looked at costs over a 1, 5 and 10 year time frame. Jonathan's already mentioned some of these numbers, but in terms of the returns on investments, there can be some very powerful returns. For instance, if you can prevent conduct disorders, if you can prevent conduct disorders in children, actually for every £1 you spend, over a 10-year period, you'll get £9 back in terms of the healthcare system, because you don't have to deal with so many behavioural problems, special health services for those kids. But there are other benefits to the education sector largely, in terms of the avoidance of the need for special educational services, special educational provision, exclusion from school, these kinds of things, of around £17 for every £1 you spend over a 10-year period. And then broader cost to society, around a £57 return to the economy as a whole for investing in this area. And that's in terms of people having better life chances and going into employment. It's about less violence and the consequences of violence for society as well. And even with the more modest interventions, you'll see here for postnatal depression, you spend £1 and overall you only get back 80 pence. So less than £1 back. But that is still cost effective, because for every single, it only costs around £3,000 British pounds for every additional year of good quality life gained, which in a British context would be considered a very good value for money thing to do. So not everything here has to absolutely save money. It's about, do the extra benefits gained merit spending extra money? It just so happens that a lot of these interventions actually end up saving money if you look at impacts beyond the healthcare sector. An example of this is debt advice. Financial debt is a real problem for people. It increases the risk of depression and mental health problems significantly. We looked at the impacts of investing in a debt advice service to help people reduce the risk of the stress around unmanageable financial debts, money you've borrowed. And we found that actually has a positive return overall, even though it costs the health service a lot of money in the first year. This was for 100,000 people, around £150,000 extra being spent. But you'd be saving some cost to the legal system, and then over time there will be impacts in terms of less depression, therefore less time out of work, and less costs of treating depression within the healthcare system as well. So there were cost benefits over a 5-year period, quite substantial, although in the first year it was actually going to cost you money to do this. So again, it's very important to think about the mid to long-term view as well as the short-term view. And I'm nearly up, Jonathan. So how can things be strengthened? Well, we've heard this already at this conference as well, the importance of a multi-sectoral, intersectoral approach to thinking about these issues. And that's what I think is fundamental, not just for mental health, but with everything we do here. Then when we're trying to make an economic case for action, that if we're talking to the Ministry of Education, we have to identify the education benefits. Forget the health benefits, because they may not be interested in them. But if you can prove that a health promoting intervention in the school has benefits in terms of better educational performance, less absenteeism, truancy from school, less teacher stress, all these kind of things, that will be very powerful to an education ministry who wants to invest education money in educational targets and performances. And then of course you can say on top of that, of course there are benefits to health. And I think that's something we sometimes feel uncomfortable about doing, because we're here focusing on health, but if you actually want to get things done, then I think it's important to speak the language of other sectors. And so really working perhaps with other people sometimes to quantify these non-health benefits as well as the health benefits. So some issues going forward then. I would argue strongly that economic arguments help build a case for action. And wherever you can, it's worth building in these arguments. Certainly, at the very least, try and work out how much money is being invested in an intervention, and try and identify something about the cost of doing nothing. That's a good starting point to doing things. A lot of the public health interventions, of course, they succeed or they fail based on the uptake rate, the engagement rate. So context is important. Just because something works in England doesn't mean it's going to work in Thailand. Or something that works in Thailand in a school may work in England, but only if it's adapted. So thinking about, don't assume just because something works or even if it fails, it can't work somewhere else. Look at what may need to be done to adapt it, and look at the costs of that adaptation as well. There are whole sorts of issues around well-being, which I haven't talked about at all in this presentation. There is an emerging literature on this, and I think one area in the future which would be very interesting to look at is whether or not having better well-being at one point in time is protective to your health at a future point in time. Because again, if we can demonstrate that well-being has that benefit as well, then perhaps it might encourage some people who are more sceptical about well-being to invest in well-being measures as well. So really that's all I want to say. I bombarded you with information, statistics. I did sign the form saying this presentation will be in the website or something, so you should be able to get hold of that. The Health Promotion International paper, have a look at that if you can as well. And our report for the Department of Health is also publicly available, so have a look at that and email me if you want to follow up at all. So thank you very much. And again, the conference in London next year, which will focus specifically on mental well-being, and I do hope some of you may be able to come to London and partake of our hospitality. So thank you very much. And I should now turn it over to Probity, and even though I still can't say your name properly, it's terrible. I must apologise. He's going to talk about a specific case study on mental health promotion in Thailand. Thank you.
Good afternoon, everyone. I'm Probity. I kind of wearing two hats. One is I'm a psychiatrist working for the Department of Mental Health, and I got the funding from Thai Health Promotion. So I manage part of the funding for the mental health promotion. Before I start presentation, may I ask how many of you have been doing in the field of mental health or related field? Please raise your hands. So less than half. Good. So at this moment, I hope that you can see the link between mental health and general or physical health. If you are from the field of chronic diseases or alcohol, tobacco, or substance abuse, you can see that there are many angles of relationship between mental health and the area you are working. For example, you have heard from our Jonathan and David that it's the concept of comorbidity, the co-occurrence between depression and other conditions are so having a huge impact on the prognosis and treatment costs, and it also has the impact on the prevention aspect. My presentation will be on the health promotion in the area of mental health promotion in Thailand. And when Jonathan proposed the theme, no health promotion without mental health promotion, I think it hit right into our idea of trying to present to you the linkage between mental health and other aspects of human being as a holistic term. Just to give you a brief Thai context, we are just classified as upper middle income country, and we have a population of nearly 20 million. And we have the system of universal coverage, that is everyone who are ill can have the access to health care. In the area of mental health, we have two challenges. One is that we have so limited access to care, and it is internationally phenomenon. Every country, there are very limited access to mental health care. At the same time, because the care is not enough, then should we do the mental health promotion and prevention? My argument is that yes, we have to do both. When we started the Department of Mental Health about 20 years ago, we tried to define mental health, and we got the response from different people into two broad concepts. One is that when we talk about mental health, we think about happiness. And this is usually from the local scholars, the person who are experiencing their life, really, they don't have much education, but they know a lot about human life. And when we ask about what do you think of mental health, they say happiness. The other group of people who respond as happiness is senior Buddhist monk. But most of the public, when we talk about mental health, we think about mental illnesses. So the Department of Mental Health try to define mental health in a positive way. And we have the operational definition before we were aware of the WHO definition. And that operational definition can be divided into 4 domains. That is, we define mental health of the state of happy life that consists of those and that, and divided into 4 domains. The mental state, how are you feeling? The mental capacity, how much you perceive yourself, the ability to cope with life, problem solving and relationship and feel. And mental quality, the state of mind, the gift and helping others, quality of mind. And the supporting factors, that is kind of environment, family support, income, and environment in general. Later I found the WHO definition, and it's on the web page of 2011, but Jonathan just told me that the definition has been on since 2001. You can see that the mental health is defined as a state of well-being that individual realizes his or her potential, can cope with stress, work productively, fruitfully, and contribute back to the community. So when I start thinking about mental health promotion, because lots of my colleagues are doing in the access to care for mental disorders, so I moved myself to the field of mental health promotion. I asked myself, what is the end point of mental health promotion? Then it's back to the definition. It's about happiness, well-being. It's about individual realize his or her own potential. And when we change it into some specific term, it is about national IQ, or children, the next generation IQ. It is about life skills for kids and for adults. It is about EQ, or resilience, optimism, or a new kind of mainstream phenomena is mindfulness. So we are looking at mental health promotion as the process to cultivate all this into the population. Why we need good mental health? If you listen to both speakers, you can see, and there are some other research done. In summary, the good mental health is conducive to better health and better immune function, better health behavior. It means that if you have better mental health, you tend to eat more healthy food, you choose more vegetables, you exercise more, and this links with the mental health. So if you are in any field and you try to manage change in people's behavior, looking at mental health will be a very critical element when you try to improve people's health behavior. And those who are having good mental health have longer life expectancy, better relationship, and less involved with alcohol and drugs, and better prognosis for many physical conditions and less treatment costs. So this is the link between mental health and other conditions. And this is the theme. That's why we propose the theme, no health promotion without mental health promotion. Just one slide to show you that we did a national survey and found that there are about 15% of the population experience mental disorder. And in our pilot, we found that only 11% got treated. And among that, less than half received continuous care. We developed a system to detect whether the patient is being treated, and we found that at the moment we are able to have 30% of those who should experience depression are in the treatment system. That's the end of the mental disorder angle. Now I'm going to speak to you about the mental health promotion effort in Thailand. And my proposal is that it reduces the burden. We cannot just try to manage the service system that will take better care of those who are mentally ill only. But we try to do the prevention promotion so that we reduce the burden of care. When I look at the promotion, usually we think about Ottawa Charter, right? And I really like the idea of Ottawa Charter. But how does it translate into action when we are trying to promote mental health? And this is one of our learning. First, we have to present mental health issue as the public issues, not mental health professionals issue. So when we did a survey and said how much IQ score of each province in Thailand or around the country at the moment, the IQ problem is not mental health problem anymore. It's not mental health professional issue. The governor of that province, the civic groups of the province, or the local administration of the province started to look at their own IQ and their area IQ, and they started to talk about how we can raise our kids' IQ. In other words, we use the area-based information, the IQ of each province, and give it back to the province, and all the sectors in that province will own that information and feel some urge to do something by their own, because it's not an issue of the central government office to do the IQ promotion for each province. We take it back to the area. And all of this, happiness, life skills, preventing health and social problems such as teen pregnancy, which is more concrete for people in the field. When we present mental health promotion in this angle, usually it sells much better than we talk about mental health in the generic way or mental disorders. My approach has been trying to link between area-based information and initiate local programs and intersectoral forums and community learning with the tools of knowledge management and user-friendly tools and evaluation and feedback. And what I'm going to present to you will be detail some of this. The idea is that area-based information creates sense of ownership and help drive movement. And this is my first experience when I was much younger than now. I was invited to attend a forum in the district level. In that district, a psychiatric nurse. In that district, it was the highest suicide rate in the province. And that province has the highest suicide rate of the country. So with that district meeting, the psychiatric nurse proposed to present the suicide rate of each sub-district region. And she invited all stakeholders, community leaders, district officers, educators, Buddhist monks, and volunteers. And when they look at data, in my area, there are 5 people killed themselves last year. And this calculates back into the rate of the highest in this province, this district, which is highest of the country. Now there's kind of sense of this ownership, and they discuss, they think of what happened with that people, those people who killed themselves. It's their real life experience. Then they got the idea of what they want to do. And one of the solutions that I was very impressed at that time, they start talking about suicide, but they came out with alcohol, the ban. Alcohol will be banned in all community events. Now, usually we don't see this link, but we know that it's linked, because the direct experience of people in the field see that linkage. But sometimes when we work at the central office and we separate by our own area, we may not see that link as concretely as the people in the field. And suicide has been raised as an issue up to the cabinet because of that sense of ownership from the province level, the regional level, up to the national level. And we have the law mechanism to propose what people think is important up to the cabinet. But after the cabinet approval, the downstream effort has not been so much fruitful. I'm going to focus more on the happiness as the other example. We try from that idea that we have to create the area-based information, and we try to present to the field how happy your people are, how happy these prevents are. And we just tell them the information, and we don't try to do anything with them, except when they want to do something with us. Then we go and work with them. And we rank the happiness level. At the same time, because of the survey nature, we were able to study the determinant of mental health, of happiness. and we provide multi-sectoral forums. This is the part of the tools to measure mental health, but later because of the short version we call it Thai happiness. We have 15 questions, and I cannot go into detail, but if you are interested in looking into more detail, we have the board exhibition, and it's interactive board. You can go into the Thai health exhibition zone. But when we use this survey mix blend with it into all the National Statistical Office survey, they put it into the socio-economic survey, socio-cultural survey, health welfare survey, elderly survey. So we were able to link between this scale, the happiness scale, with other variables, socio-economic, cultural, and health. So we were able to see the link between the happiness scale scores and other variables from this collaboration with the National Statistical Office. And we came out with this, and most of the results are quite similar to the international literature, that if your family is having a good have time together, having activities together, then you have higher happiness score. This is just an example. We also was able to find out some of the determinants for unhappiness. For example, we found that the debt, if you got the bank loan, it doesn't affect your happiness level. But if you are in the shark loan, then the happiness level came down very, very deeply. If you are a farmer and you have your own land, then your happy is very good, happiness level. But if you are a farmer and you don't own your land, then your happiness level is very down. We have not been able to move forward in the area of trying to clear the debt loan, the shark loan in the country, or trying to pursue the land ownership issues. All of these are quite political issues. But we tell every people or every parties we work with that this is what we call determinants of unhappiness, or the risk factors for mental health or well-being. So with this, we know more about risk factors and protective factors in Thai context. Now when we have that, and we present it into the area where they want to work something with us, they start to question my colleagues and I, how we can work with the happiness level in our area. Then later we found that the only way to make it a concrete approach is to look at specific population they want to improve the happiness level. And we found that most of the area will choose youth and elderly as the most common population that they want to invest to increase the level of happiness. Now when they want to do it, again they want to invite experts from somewhere else and work with them, and of course we haven't got enough number of mental health professionals who know about positive mental health to work with all the people. The demand, when they want to do something, we cannot work with them. So we know that professional support for the field who want to do something about well-being and happiness is not enough, and it will never be enough. So we were thinking of creating some tools that doesn't have to rely on professional experts, but the community can do the work, or the non-professional can do the work themselves. So we apply the learning tools, and when they do it, they're satisfied with the results, so they do more. And when they do more, the politicians at the local level got hooked, and they promised to work with the civic group and with the community to invest in this field because they get the result. But before that, when they want to do something in youth, usually they discuss a lot. Then they have limited amount of money. They can only train some core leaders of youth, and usually it has no impact in the field. But now when we try to support them with the tools, they can make use of the tools to create a learning forum in the field, in the community, and it creates a kind of momentum to be aware of what they can do to promote well-being or happiness among that group. And because of the time, I will present only the youth. I have to go very quickly now. Please come with me. There are two programs. One is the life skills resilience development in school. The other is the out of school or after school youth public space. And we develop these tools for teachers and parents to learn. Teachers apply by using it with the children in the class, and also create a learning forum for parents. It's a kind of emotional and social skills development for youth without having to rely on mental health professionals. It's about training parenting skills for parents without having to rely on mental health professionals. So they use the tools. So anyone who wants to do it can do it by themselves. Of course, if they have basic knowledge and if they have facilitating skills, that will be much better, because we found later that the facilitating skills is very critical in this process. And we did a quasi-experiment for the tool, that the resilience development, 800 sample control and test. And using the SDQ, the Strength Difficulty Questionnaire, an international standard questionnaire, measures to measure students or kids' behavior and emotion. And there are three forms of report. One is the student report themselves, and they witness that there are kind of less problem behavior among them, their peers and themselves. And for teachers, they report improve of the emotional symptom scale, improvement of the hyperactivity scale. In other words, children are less hyperactive, and peers' problems are less, and pro-social skills are better. In the interview, students say they have a better sense of purpose and better relationship, and teachers say that there are much less burden for them in trying to manage kids' problems. And they also see that students have better sexual behavior. In other words, when we provide the learning in the resilience, which is social and emotional skills, it helps protect them in many health problems that's common happen among youth. So one intervention prevent many health problems or behavioral problems in this population. And also, kids say they improve learning attention. Teachers say they kind of pay more attention when they learn. And they have better relationship. Kids have reduced school absence, behavioral problems, and fighting. All these are from teachers and kids speaking to us when we have the follow-up and knowledge management forum. And many students said about they have a better sense of purpose, and some of the kids who have been smoking volunteer to stop smoking. And increased cooperation between the different sectors in the community. And I think the most critical one is that if they like it, if they like the idea and the experience, they can scale up by themselves, not having to come back and demand for more support. I'm going to just tell you that we are also experimenting the after-school youth public space, and it was demonstrated that it reduced substance use among previous users, and it increased higher education among youth in the deprived and poverty area, and reduce violence and fighting among youth from different zones in the community, and improve elderly mental health and community livelihood, because the youth after school youth public space invite elderly to train youth in the skills youth want to learn, such as the traditional food or traditional music. So there are double benefit. Elderly who come to train have a good sense of pride and sense of esteem when they can train the kids, and the kids learn from the elderly, and they get the skills they want, and they have fun with what they want to learn. I will pass all of this and just tell you that one of the teacher counselor told us in the interview that children problems at school are much less after using the media. It helps reduce my workload as school counselor a lot. They are now more responsible, helping each other, and have better relationships with their parents. These are conditions teachers want to have, but they don't see that mental health promotion can answer their question. Now we try to tell them that this is the answer for your question. It's not my job, it's your job. And in some places it took more than a year before teachers realized that this is their job, mental health promotion. For kids it's their job, not my job. Also, one community nurse said, in the past it was like a work alone to prevent teenage pregnancy. Well, schools are not so much keen on teenage pregnancy. they think this is a health problem, so the health sector should be responsible for it. Now, teachers and schools and other parties help work together and it shows result. I think this is the nearly last slide. So the key ingredients that my colleagues and I have been trying to do is to develop the sense of ownership of the community and let them create their own program, supporting them the tools that they can run the activities themselves, and provide a learning forum for them so that they gain more confidence. And with that, we don't have to talk to the politician at the local level. They will follow the community effort themselves. One thing that has not been our intention at the beginning, but the health system changed the way they work with other sectors, because they know that they cannot say, to prevent youth problem, they cannot go all to the school and try to educate kids, giving a brief information. So they change the way by presenting the information that is the language of that parties, and stimulate the work by providing tools that teachers can use, and it solves all the sector's issues together. And that's why, coming back to the theme of this rule, no health promotion without mental health promotion. Thank you for your attention. I'm aware of the time, that is 5 o'clock. I'm not sure if how should we do it. Any questions, or should we stop now?
We could have time for questions if people want to ask questions.
Okay, time for questions. Briefly? Okay.
Yeah.
Okay, please. Any?
Hi there, I'm Lorna Smith. I work for Health Scotland, and I previously worked on our national mental health improvement team. And last year we were involved in the mental health strategy for Scotland being developed, which from a public health perspective was largely unsuccessful, despite our best efforts of providing many of the references you provided today and conducting many consultations from a public health perspective. And ultimately, the mental health team within the government were pressured by the things that make the press and the things that the minister can say on a 4-year election cycle, as opposed to the long-term benefits. And our mental health strategy, as a result, addresses only early intervention and treatment and care. And the response was that, well, it's implicit that mental health improvement will go on by other sectors and in other policies. However, within those policies of education and parenting, in sport, it's also implicit. So my question is really, how can, as people who passionately believe in mental health improvement, and thank you for all your presentations, it was wonderful, how can we better articulate the case so that there's a shared ownership, but there's also leadership from the mental health workforce, which certainly in Scotland we're really challenged by.
Thank you very much. I actually wanted to ask a related question, so I just wanted to dive in there. Paola Ardiles from Canada. I've recently had the privilege of talking to a lot of policymakers in Canada who have been implementing a lot of provincial action plans. And what I heard from a lot of the very high-level policy decision makers is that they understand that applying a mental health promotion intervention has multiple outcomes that are long-term and that we don't necessarily measure, but there's also the benefit of being able to explain to another sector that the implications that, for example, a parenting program might also reduce, level of unemployment for that if there's a single parent, that they might also have benefit in terms of unemployment, but they might also benefit in terms of the bond between the child and the mother, that they also might bond because they're more included in the community, because they can seek other services earlier, they have a higher level of education after they go through the program. So there's so many multiple outcomes from one intervention. So I guess my question to you is, how do you show that? How do you show the evidence? Because the outcomes are actually in so many of the other sectors. And so, it would just be wonderful to be able to actually demonstrate that to the decision makers, because that's what they want to see. They want to see that, you know, you're investing in mental health, but that the outcomes are multiple. So I just don't know where the field is at in terms of actually being able to show that cost effectiveness at that multiple sectoral level.
So, so thanks. Yeah, maybe if I just sort of respond to the question about the difficulty of implementation. I think I spent several years at the UK's England Department of Health putting together the evidence base, and then I slightly naively thought that if we could get all the evidence base into policy and say all the right things, then everything would happen. That's not the case. What's required is, I think, consistent and continuing advocacy from a broad range of stakeholders, not just within health, but particularly the third sector voluntary organisations who've been very powerful in the UK at lobbying. Despite all the great work that David and colleagues did from the LSE, we've actually, and also a very clear evidence that it's only a minority of people with mental disorder get any treatment, and there's virtually no spend on promotional prevention. Despite all the returns, we've actually had a reduction in our mental health budget in the last year. So I think there's something then to be said for, well, actually, we're looking at a slightly more difficult issue, and I think Prowett's kind of example of localism is very interesting. I sort of highlighted some guidance, and I've applied that locally to a region of 700,000, and then showed different local sectors within that area, the costs of mental disorder. And now they're seeing, for instance, the cost of conduct disorder each year. A one-year cohort of children and adolescents with conduct disorder costs £800 million. That's the lifetime costs. And actually most of that is hit in the criminal justice sector. So there's something around national policies which are quite difficult for people, stakeholders, to apply. I think Prowett's example of actually take-up and almost kind of mainstreaming from the grassroots up is a really nice example, and I think applying pressure to your local politician through, for instance, the transparency argument, well, why is it only 10% of people with drug dependence get any intervention, and look at the cost of that. So there's something about slightly turning it around. It's been my own experience, because I was quite disappointed having spent, as I said, all this time. But I think it's also a consistent message to an engagement with a broad range of stakeholders that sometimes people in health they're not so good at doing. And so I'm working with the Public Health Department at the moment, and I've learnt a lot. And I've just been aware also that their knowledge about mental health was actually quite limited. And so we've both learnt a tremendous amount, and through that engagement, I think we've got, but it's kind of more local level, but then using those examples to inspire nationally. So, but maybe if I hand over to David about the savings across a broad range of sectors.
Yeah, there absolutely are ways of doing this. Now, if you try and simply report cost per quality adjusted life or disability adjusted life years, it doesn't really get covered very well. But what we tend to do, because mental health is messy, but this also applies to complex interventions in general, is we try and report separately the impacts on different outcomes, whether they're health, whether they're social care, education or transport. We report them separately, and we leave it up to the decision makers to decide on how important those decisions are. I mean, you know, obviously some will have more importance than others, but if we were making an argument to an education department, we would absolutely focus on the education arguments. We'll be looking at school attendance, school performance in the regular tests that people have, the impacts on classroom disruption. We'd make sure that we would, if we were doing an evaluation, we would make sure we'd be capturing that kind of information in addition to the things that we may be more interested in terms of mental health. But there never will be one composite way other than doing something called cost-benefit analysis, which is trying to put a monetary value on everything. But that has disadvantages as well as advantages. One other thing just to say, to come back to the point on how to get things to happen, this is probably not very helpful, but actually money can help as well in the sense that if you have some shared budgets for some shared common objectives, then everyone has a responsibility for the money, and everyone can feel, hopefully, the benefits of doing more with that money. There are some examples of where that's been done. For instance, for people who have both mental or back-related problems that keep them out of work, you can have a shared budget for the mental health department, the social security or welfare department, and the work department to try and develop an approach to helping people return to work. And so it is possible to do these things, and sometimes it's practical things. In Scotland, probably all these people work fairly close to each other geographically because everything's in Glasgow or Edinburgh, basically. And so there may be ways of actually co-locating people a bit more easily so they physically meet each other more often and actually start having dialogues as well. Because I know our colleague from Scotland was complaining about the Scots system, but it seems to me the smaller the country, the more chance there is of something happening, which perhaps also links to this localism business. Because an example we didn't mention today, but very fascinating, is what's been going on in Iceland. Iceland's a very small country, 350,000 people. But they've had a huge focus on well-being and happiness. They developed a kind of mental health first aid approach to dealing with the economic crisis, which really hit them very hard indeed. And their mental health outcomes are pretty positive, actually, a few years after the crisis now. And, but what they could do there may not be done in a larger country, but it might be done in a county or a region of a larger country. And I think it's also vital, the grassroots, the community, the volunteers getting on board as well. In the UK, we're quite lucky because we have quite active non-governmental organisations, which I know is not the case everywhere, but that's another important thing. Faith groups can also help as well with these kinds of things, or other community groups. I know we're really over time. Robert, do you want to add anything at all? Does anyone have any last question at all? Because I thank you for your patience because we've overrun, but I hope you've found it useful. Any last burning questions from anyone or comments? Or you're all desperate to get out of the room?
Could I just add something, maybe just as a last acknowledgement, really, of the Thai Department of Mental Health, because I think, I think it's just such inspiring work that you're doing here, and certainly I've learned a tremendous amount, and also to acknowledge your tremendous generosity as well. I mean, we're here and very pleased to be invited, and so thank you very much for both inviting us here, but also to share and learn from fantastic work going on in Thailand.
Thank you.